failure clinic, which is very popular at these days. And what this study has shown is that the survival of patients that were under nurse care, so in a heart failure clinic, is about as good as patients that are on remote monitoring. But what we can do with implantable monitors is also go to the patients that are relatively sick, but not sick enough to be a candidate for an ICD or a cardiac resynchronization therapy, because then your ejection fraction needs to be below 35%. So there's a large cohort of patients that has an ejection fraction of more than 35%, but you see their annual mortality rate is still around 25%, so it's very high. Now these patients are now under the nurse care or maybe some form of telemonitoring, and these patients are at high risk of having hospitalizations, having arrhythmias, etc. So are, in my opinion, perfect candidates for continuous monitoring. So what we should try to achieve in these patients is predict hospitalization, so try to estimate when they accumulate fluid, call them, instruct them to increase the diuretics, and then hopefully keep them out of the hospital. Arrhythmia monitoring, I think, is very important because that may actually also shift them to the therapeutic devices, and of course overall risk assessment. And this is a nice slide from one of the therapeutic devices, but basically nowadays those parameters are also available in an insertable monitor. This is a patient that actually was hospitalized for heart failure at point 0, and you can see that already something like 3 weeks earlier, you see that heart rate variability was going down continuously. The average heart rate during the night was increasing continuously, and the patient activity was going down. And so if you add up these 3 signals already, you could have predicted the heart failure event in this patient. If you add other parameters to that, like respiratory rate, like fluid accumulation, the predictive value will even be higher. So
5 minutes, please.
Okay. This is some of the research that we are currently doing by using impedance sensing in the device. This is the impedance signal. You can see definitely the respiratory component is very big. You see a smaller cardiac component, which also could be very useful. And you also, of course, have the mean impedance, which has some correlation to the amount of fluids that is near to the device. In this case, those are, of course, then not pulmonary edema, but peripheral edema. Last slides on myocardial infarction detection. I think the biggest problem in myocardial infarction is patient denial. Sometimes patients for hours deny that they have a problem. I think this is, in most of the Western European countries, is pretty well organized. The transportation, the ambulance, once you're in the hospital, the door-to-needle or door-to-balloon time are pretty good. We put a lot of effort in that and trying to get the patient on the table as quickly as possible. As quickly as possible basically means within 90 minutes, 1.5 hours. Because after the 1.5 hours, you see that the amount of muscle that actually you lose starts to increase quite dramatically. And so the objective really is to minimize this patient delay. So you have to do that by monitoring. One of the things to do that is monitoring ST elevations. We conducted a lot of research on how good can you detect ST segment elevations by using a small single dipole ECG. We started off with PTCAs, where they inflated the balloon 1.5 minutes, and we used at all different combinations in a body surface map that have 4 centimeters difference. And we occluded different coronary arteries. And the results of all that is that there are certain positions, if you implant the loop recorder there, that with a detection level of 100 microvolts, you can have a sensitivity of 90+%. So in my opinion, that definitely does not look bad, considering that, that we were able to detect the most important coronary arteries almost 100%. And we are already in the phase of animal experiments. These are some examples from pigs, where we occluded 4 minutes after the occlusion. You can see this is the baseline ECG from 2 pigs, and here you can see the ECGs 4 minutes after the occlusion, and you can see that the device is definitely capable of picking up the ST segment changes quite easily. Last slide on future developments. Of course, everybody wants things smaller, but you have to pay the price always versus longevity. So the clinical application versus longevity, I think, is something that you need to balance very well. Long-range telemetry. Nowadays, these devices can only talk over a few centimeters. In the very near future, they will be able to talk over several meters. So you can connect to a mobile phone or bedside monitor or whatever. And then you can also think about various alerting systems. And of course, sensors play an extremely important role. We are looking at many mechanical sensors like accelerometers, piezo, especially for heart sounds. So thank you for your attention.